That is a very large, aggressive-looking, probably tumor. They found it in my nodes. They found it in my lungs. So it was like worst case scenario. I'm typically a pretty positive person. I don't look at things as to why me. I've always looked at it as, nope, that's just part of my life. It's an experience, and I'm gonna take it for what it is, and we're gonna roll with it. I really feel like it has made me try to empathize and understand where my patients are coming from. I think we all can. Remember that we're human, and sharing things about yourself is okay. Sharing a little bit of personal things with our patients, part of our journey, or where we may be able to offer a pearl or, like I said, a connection with the patient, I think it makes it a more enjoyable experience. I think that's really important. And I think that's one thing that optometry has typically done very well. And I think not losing that's really important.
Hey Eyes and Shine, and welcome to the I Give a Damn podcast, brought to you by Fluorescene Media, the same company behind Odie's on Facebook. Today's discussion features Dr. Cecelia Koetting, where we get to hear more about some of her famous CE lecture topics, including that of the treatment of limbal stem cell deficiency, but also that of hormone replacement therapy. We then get to hear about her personal battle with cancer. This is a huge and really important topic to be touching on because it affects almost all of us in some way. And here, Dr. Koetting shares her experience battling cancer, but also how afterward it has reshaped her life, including how it's affected her work, but also her patient care. So again, a huge topic, and I'm so grateful for Dr. Koetting for sharing her experience with us. So without further ado, please join us here today, tune in, and let's hear from Dr. Cecelia Koetting. Again, Cecelia, thank you so much for being a guest here on the podcast, taking some time out of your busy day here at Academy. We know we're always rushing from one meeting to the next, so just appreciate you coming on.
I appreciate getting a chance to sit down and chat with a friend.
With all of the guests, I love getting to know and hearing your story. How did you find optometry to begin with?
So, I am actually a third-generation optometrist. However, that is not how I found it. I went to undergrad, and at that point thought I was going to go to med school. I kept going back and forth between being forensic pathologist and going in that direction versus working in pediatric oncology. Very different spectrums. Yeah. So in the thought process of let's figure this out, I went ahead and started volunteering in the pediatric ward, the oncology ward, and really quickly realized for me and my personality and being empathetic, I was taking a lot of it home, and I was like, I don't know that that's going to work. So I went ahead, graduated, and worked in biotech. So I worked for a small independent company that was going through FDA trials, and I was their microbiology department, so their quality control. I helped develop that, learn how to write SOPs, develop all of these protocols for actually testing the product and the how it was being made and things like that, which was really cool. But then I also realized that was really boring because I worked with the same 6 people all day, every day. Yeah. So I was trying to figure out, put the thinking cap on, what do I want to do? And I shadowed a lot of doctors, and optometry came up, and I was like, well, you know what? My dad was practice manager. He was always home. My grandfather did it, did well for himself, but was still home on weekends, had a family, had a life. Maybe I should do that. So I went ahead and started shadowing back at my grandfather's practice, who had since retired, and shadowed Carmen Castellano, who's the owner, and was like, okay, I like this. This is cool. And then I applied for a job to be a tech. And Carmen was like, why didn't you just ask for one? And I said, well, I wanted to be hired like a normal person. So I worked there as a tech for about a year while I was applying to optometry school. So that was my intro into optometry.
Amazing. It is fascinating how many people do have some family heritage in the profession. And then there's a lot of us who just, no, not at all. We just got inspired by our own optometrist or something. Yeah. So you've taken a winding road in optometry, but you present on so many different topics, right? You present on not just anterior segment sort of things, but you talk about neuro and then co-management, surgical co-management. Do you have like a specific passion in eye care, something that you really, do you just get excited about and look forward to learning, reading more?
I think I constantly, so the way I end up writing a lot of my lectures is I don't know an answer to that question. That means I'm not the only person. So let's dive deeper into it. And it kind of pushes me into having to learn myself. Where does my day-to-day passion? It really has changed. Just like you said, I've kind of had a little winding road, and I've worked in places where I've been able to change up what I'm doing, and as far as like where I'm kind of specializing and working as a retina extender, working as a glaucoma extender, working as a cornea extender, but where I've really kind of found myself doing very well and being able to really help my patients is probably more ocular surface disease and cornea, whether that be co-management with surgical or just in general kind of helping taking care of a lot of those patients, as well as neuro, which I still feel really kind of piggyback off of each other when we start getting down into the neuro part of it, as far as the cornea being neurotrophic keratitis and neuropathic and all of these things. That kind of starts to go into that direction as well.
And I think just the reality is like there's not a single patient that you're going to see in the clinic where you're not in some form evaluating their neurological status.
Yes.
Right? Just
absolutely.
watching them look their eyes left and right, you're automatically just like, okay, you can move cranial nerve 3, 6. You're starting to pick apart those things.
Yes.
Being that you have a lot of lectures, two big topics that I think are very interesting and I would like to give more air to. One is limbal stem cell deficiency, and then the other one is more on the lines of the hormone replacement therapy. Because again, those are two things that I think we all learn about to some degree and maybe think about and probably see, but it's not something we talk about as much and maybe aren't as prepared for.
I would 100% say that everybody sees limbal stem cell deficiency. We just don't realize it.
Yeah.
We chalk it up to being SBK or being corneal staining and not realizing that we're actually seeing early damage to those stem cells or dysfunction. What I like to tell my patients is that those limbal stem cells are kind of like stunned. They're not dead. They're not fully unworking, but especially in those early phases or the, stage 1, we probably all see a lot more of it. And that's why I like to lecture on it, because I think we need to really be aggressive in those situations, because that could very quickly move into stage 2 or 3 if we're not looking for it. And those patients, when we're staining them, which please put stain on your patients, when you're looking at the fluorescene staining patterns, you really have to think about what are you seeing and where. Because if you're seeing like a diffuse SBK, and you're seeing, all these little pinpoints, right? We're probably thinking like metamucosa. What if you see that you've got a quadrant up in superior temporal and you've got kind of like a little bit of a whorl pattern going towards it? Does that make sense that we would have it up there? Why do we not have it anywhere else? Right. Versus somebody who's got inferior 1/3 staining, we might be thinking that they're sleeping with their eyes partially open.
Some exposure, right?
Exposure, exactly. So when we start looking at the type of staining and really dissecting where we're seeing it and what it looks like, that gives us a better idea to start thinking something else. Now, even in those two first cases, other cases that I suggested where it's metamucosa, if you see staining that's not true pinpoint, but you're seeing more of like an elongated rice-like staining, especially towards the periphery where the limbal stem cells are, that might be an indicator that we're having some dysfunction of those stem cells, and we probably want to be a little bit more aggressive as far as removing whatever the cause is, whether it be inflammation or actual mechanical, like rubbing from a poor-fitting contact lens or somebody who's sleeping in their contact lenses versus somebody who has sleeping with their eyes open. That can lead to it. Also thinking about actual toxicity from other drops that we've got patients on that maybe contain BAK.
So long-term toxicity maybe not necessarily causing death to the limbal stem cells, but like you said, it's
correct.
affecting them negatively in terms of their overall health and production.
And I think when a lot of us think about limbal stem cell deficiency, we think of like that end stage or like people getting really far into it. But you'll actually start to catch a lot of patients that are in those earlier stages.
And I think that's really helpful because for myself, my initial thought when I think limbal stem cell, I'm just thinking someone had a horrible chemical burn, right? And then that's kind of the real classic one. That's
exactly.
the image you think of from what you learned in school.
Yeah, that textbook picture.
But that early gray beginning, that's the challenging spot.
It is. And I think if people look for it, they'll realize a lot more patients have it.
Right.
Yeah.
And I think once you kind of get into that level of extreme dry eye / limbal stems, early limbal stem cell and even early neurotrophic.
No, because there you go. It starts to bleed into each other.
They all kind of have that similar. You start to see some edema. You start seeing some breakdown and maybe some haze even. So it's
it just depends. Yeah.
With going from limbal stem cell, how about hormonal replacement therapy?
That actually is a really good transition because hormones and hormone fluctuations in the body can lead to worsening of dry eye. And I actually see a fair amount of my patients who, and this lecture born out of necessity because I have a lot of patients in the last 2 years who are on either replacement therapy post-menopause, or I've got patients who are in transition and are on testosterone. And so when I see my patients on T, I've noticed that there's a lot more issues with meibomian gland dysfunction and moving into limbal stem cell, just depending on the severity of it. But as we get fluctuations in hormone, whether that be through our lifetime, right, because they're going to change, or through replacement, we're going to see changes in the patient's tear film and their overall just functionality, pH of the skin, things like that. Yeah.
Now, with hormone replacement therapy, whether it be estrogen, testosterone, it was potentially used as a therapy for dry eye.
Yes. And so that's the interesting thing, because when it really comes down to it, it's about balance. If you give too much or too little of one or the other, we get this dysfunction, right? And that's when we talk about dry eye and ocular surface disease, we're always talking about balance, because when you lose the balance, then we start going one way or another. Too much testosterone, too little estrogen can cause a problem. But there's a lot of studies looking at both of those as potential therapies.
What can we do as a professional, though? Because that's a frustrating thing, right? Like, they're already being prescribed this and being managed by their other doctor.
And we're not gonna, and in those situations, there's a lot of thought going into why they may be on that for one reason or another. So we're not gonna stop them, but we're gonna do the same thing we do for anybody, right? When patients, if they're going through masculinization and they're on testosterone for that reason, it's actually very similar to going through puberty. What do we do for our patients going through puberty? We talk about lid hygiene, warm compresses. We, depending if they're having some like ocular rosacea, we may talk about putting them on like a Z-Pack or something like that to kind of manage it. But we just have to manage the symptoms that go along with it. And that's going to depend on what you're looking at.
That actually helps me a lot, because I think of whenever I have young teenagers, usually they're first getting contacts or something like that, I always sprinkle in, when I was your age, I wish somebody would have told me to wash my face twice a day. Like, how much that made a difference in terms of my complexion. Because as a kid in junior high, it's like, oh, now I don't want pimples and things like that.
Right.
And so I kind of mix in, well, it turns out your eyelids end up getting a lot of oils too, and so we want you to start, because usually that's when I start seeing bleph show up more.
Yeah.
And so that's when I start incorporating that. So that's going to help me tie in that memory that, hey, if I have patients who are on these exogenous hormones, to at least go that little bit extra just to have that conversation.
And I think they appreciate it a lot, because somebody's taking the time as a doctor to say, hey, these are some things you may experience with this. And because, it typically takes about 3 to 6 months, and they actually start to ramp up the amount of testosterone that's being taken. So it will continue to change, but just giving them a heads up and,
Right.
how to deal with it.
There's a good chance that their endocrinologist or whoever who's managing them is probably not giving them that.
Not
they
from an
don't have-
ocular standpoint.
Yeah,
No,
they're not going to
no.
really break down all those specifics.
Yeah.
So, kind of to change things up a little bit, I would love to hear something a little bit more of your personal history, because you're a cancer survivor.
I am.
And so, if you wouldn't mind sharing with us just kind of your story and how that came to be and how it has affected you.
Yeah. So in 2019, end of 2019, I had started to train for a marathon. Again, I hadn't ran in a while. It'd been probably not to that extent, and probably 4 years or so. And so I was starting to get what I thought was being in my mid-30s hemorrhoids. And so I kind of just chalked it up and was like, not a big deal. It's fine. Kept getting a little bit worse. Was having significant bleeding and pain. And, I was running a fair amount, but I was like, even if that is what it is, I should probably talk to my doctor.
Yeah.
So I went to my primary care doctor and she said, okay, that's probably what it is. I'm going to send you over to the gastroenterologist so that they can
Just sign
do what they
off on
do,
it, yeah.
right? And then either decide if we're going to have surgery or not. And so next step from that, see the gastroenterologist, and they're like, cool, yeah, let's go to colonoscopy. That's what we always have to do before we can have surgery. And so I go to get my colonoscopy, and they come out and they say, that is not a hemorrhoid. That is a very large, aggressive-looking, probably tumor. So they went ahead and they took a biopsy when they were doing it and sent it off, but, had already given me the heads up that be prepared that that's probably not a good thing.
Can I ask?
Yeah.
If you remember at that time, what was all going through your head?
Oh, a lot.
Yeah.
Especially being in the healthcare profession, right? So this was actually January. By the time I got the colonoscopy, it was February of 2020. Yes.
Right when things are
Right.
about to come
Yep.
crashing down.
So I'm thinking, okay, so I know next steps. I tend to, in stressful situations, be really practical and go, okay, my husband and I, immediately had a cry, ate some Mexican and said, okay, what's the next steps?
Good to know if we need to deliver you bad news.
Give me Mexican, give me food.
Okay.
Yes. So the thoughts were, okay, well, the next steps are going to be, I'm going to need to they're going to do they already did a biopsy. I'm probably going to need to have a scan. They're going to do blood work. We're going to figure out the staging, which then means I'm going to need to go talk with other doctors. I'm going to need to let work know I'm going to have a bunch of appointments. And so I was like, well, I'll wait till I get the biopsy results, but kind of gearing up in my head for things that may come. I did not do any research. I did not look at statistics. I did not want to know anything more than, because it doesn't matter. A statistic's a statistic, and I'm going to go from here, and I'm going to do what my doctors tell me I need to do. Yeah. So that was kind of what was going through my head. We got the results back. Trying to think of where I was. I was skiing. And unfortunately, it came back. So I did my scans and everything. I met with them. And it came back that it was stage 4. They found it in my nodes. They found it in my lungs.
Whoa.
Yes. So it was like worst case scenario. But at least I was skiing. So I had a little happy place there. And it was with family. So family and friends. And they all kind of lifted me up. Yeah. But I was like, okay, so... well, that means we're going to be doing chemo, radiation, and surgery, and it's going to be pretty aggressive. So I was kind of trying to figure out, that's going to be a lot of how am I going to get around this with work? What am I going to do? How am I going to make this happen? And the next week, I was in Atlanta for SECO, or I went to SECO, and everything shut down.
Oh, sure.
That's when we got our news for 2020 that COVID was a real thing. So there was a little unfortunate blessing in disguise with that was, as we know, everything shut down. Patient care shut down. I ended up going back and starting all of my treatment. Work was fantastic. I was still with Virginia Eye Consultants, and they were my family away from home because we didn't have any family that lived there. So my husband and I really relied on them. They set up meal trains. They allowed me to work from home. I started and manned our telehealth from home. So I was still able to contribute. But to be honest, most of us weren't working anyway. So we, just kind of trucked through. The hard thing I will say is because of COVID, there was no, there were no support groups. My husband wasn't allowed in for my treatments. So chemo was done by myself. They did allow him in for the first one, but usually it was just me hanging out in there with other people going through it. But I did chemo for March through July. Then I got a month off. In that meantime, we actually did a biopsy of my lungs. We found out that it was the spot in the lung, thankfully, was not a metastasis. So I got downgraded to stage 3, which is good.
Yeah.
We'll take that. Yep. And, at the end of my chemo, things were shrinking, and then did chemo radiation for a month in August, and I had my final surgery for the resection of everything in November. It was on my anniversary, our wedding anniversary. Wow. My husband was like, well, cool. This is one for the books. But no, everything thankfully came out well. Some people have seen my posts. I do post. I have an ostomy. It's a bummer. I lost something, but I gained something. It's a little bit of a weird thing to deal with, but it definitely does not stop me.
Yeah.
Yeah.
And I appreciate you sharing all of this because it's a real thing that affects us.
It is. It is. And actually, especially since I had colorectal cancer, we're finding that there are a significant amount of people younger and younger having it. And the problem is because of where it is. I actually had symptoms. Many times people don't have symptoms because it may be elsewhere in the digestive tract. And so by the time it gets diagnosed for one way or another, it tends to be pretty progressed.
Do we know why people are maybe getting this more?
So that's a really good question. There's the doctor that I see now in Colorado who's actually doing research on it. And I was reading something he published recently, and there's some consideration as to our gut biome. And being a change in our gut biome, creating more toxicity or something along that, that
chronic inflammation.
Right, chronic inflammation or something that's now causing us to develop these cancers at such a young age. So it really is, it's a really good question.
It seems like, when you try to think what could possibly, is it something in your environment? Hopefully you're not around radiation or,
right. Well,
or toxic waste, not like that, but it's.
And for majority of my life, I've actually been a vegetarian, like off and on to varying degrees, but red meat and things like that, not really, and there's talk about that.
There's some statistics about that increasing your risk factors.
Yeah, exactly. And now there's also the consideration of GMOs and the risk concerns that come along with that. But yeah, there's something going on.
Right. And then possible pesticides and then you get into the debate about organic food versus non-organic.
Yeah.
So maybe beyond our talk here.
I know. We're here talking about eyes, but definitely it is an interesting thing.
First, because we all have patients who go through cancer, who battle cancer. Thank goodness you were able to beat it in remission and all of that. How did any of this change, first on a personal level, your outlook on life? And then the second part, I'm curious of just how has it changed your practice, your relationship with patients in any degree?
It's definitely changed both. The outlook overall has maintained. I am typically a pretty positive person. I don't look at things as to why me. I've always looked at it as, nope, that's just part of my life. It's an experience, and I'm going to take it for what it is, and we're gonna roll with it. And thankfully, I had that attitude. I think it really definitely helped with making it through all of that. But even now, post-COVID, post that, part of the reason my husband and I picked up and moved was because we decided, hey, life is short, and what makes us happy, and where do we want to be that's going to make us happy? Because work is work, and I should enjoy it because I spend a lot of time there, and I do love my patients, but we needed a little bit about a better balance, and I'm still working on trying to figure out that balance, but that was part of what moved us out there. The other thing was, unfortunately, because at that same time we were trying to have kids, that ship has sailed for us in that capacity,
I'm sorry that's not an option going forward.
Which is okay. Yeah. Again, I take things as I can. But with work, I really feel like for me, it has made me try to empathize and understand where my patients are coming from. That patient who might be yelling at me right now, maybe I'm also feeling like yelling because I'm having a bad day, right? So they're probably having a bad day. So trying to connect and figure out why they're feeling that way. And also with patients because with ocular surface disease, I see a fair amount of patients who are going through chemo or cancer or trying to connect with them and making sure that they, if I can make them feel like part of the community, or it also helps me too to have somebody to discuss with. I try to connect with them if I can.
Do you think there's anything that other eye doctors that you could tips or share, or something you think that we could maybe do better to connect and communicate with our patients?
I think we all can. Remember that we're human, and sharing things about yourself is okay. We don't need to be the doctor that's in the room and I'm not a human. No, I'm a human. And I think that sharing a little bit of personal things with our patients, part of our journey, or where we may be able to offer a pearl, or like I said, a connection with the patient, I think it makes it a more enjoyable experience for everyone.
Right.
And I think that's really important. And I think that's one thing that optometry has typically done very well, is being more personable than other disciplines. And I think not losing that's really important.
I think so too. And it's challenging, again, just because things like healthcare and everything's always pushing us to have less and less time with our patients.
Less connection, more patients.
Right.
Yeah.
And who knows how things will change with virtual visits and things like that, right?
Yeah.
But at the same time, it seems like a lot of people want less connection in some ways.
Yeah.
Maybe not with their doctor, but some people, like myself, the other day I'm like, oh, I have to go into the store because I can't buy it online. Yes. I was frustrated by that. I'm like, I don't want to talk to somebody. It's not always that case, but
no. And it's nice that we have options, but I think that we need to probably also just in general make sure that we're not completely moving away from all of those connections and still maintaining, human to human conversations like this. We could have very well have done this via Zoom, but this is way more fun to be in room and with a person.
Absolutely.
Yeah.
So again, you have so many different projects, and you just accepted a new position at the, correct me, it's
University of Colorado School of Medicine on the Anschutz campus.
It's amazing. And you're there a couple of days a week, and that's just an amazing opportunity, and congratulations for that.
Yeah, I'm enjoying it. Thank you.
With kind of going forward, do you have any other kind of passions, projects you're working on, CE that you're really excited to dig more into the publications to create?
Yes, all the above. I'm always kind of looking for different things, but the big one right now that is taking up some time is I actually started my master's in public health in epidemiology and biostatistics. So I'm taking some classes on that. It's something I've wanted to do, but I also I want to do this so that it kind of gives me more food for thought and a different perspective. Why do we continue to educate ourselves? And that's why. It's so that maybe I can start to look at optometry a little bit differently, or eye care in general,
right.
And identify areas that maybe we can improve or things that I can bring to the table for our profession.
Why public health? Why masters in public health? It sounds like you've thought about it for a while.
I have, and I kept oscillating back and forth as to where to go with it. And I feel like with being able to maybe look at numbers and statistics and things like that in that direction, and just kind of looking at the types of classes, it seemed to be a good fit for me versus necessarily like maybe the business end or some other directions.
Right.
Yeah.
Well, I applaud you for it. It's something I've briefly looked into myself. Before I started anything on social media, I'm like, I need to get a master's in public health. But then I stopped and I'm like, do I really need it to do social media?
And I have oscillated so many years to say, do I want to? Do I need to? And I think it's a little bit of want.
Good.
Yeah.
That's probably...
Probably more want than yes, because I know is it necessarily applicable? I don't know. We'll see. But I want to do it.
Yeah.
So
It sounds like you're interested in learning that level of kind of the science in that regard. And you've had some experience from a couple of different points of view.
Exactly. Yeah.
The big question I always like to ask people now, because it gives a really good frame of reference of what you care about, what you love in our profession, of what you think would maybe improve our profession, is if you were to wake up the next day and you were appointed to be kind of the Surgeon General of optometry, you were kind of the head person to choose, okay, what needs to change either in the profession, within healthcare in general, or one thing you wish you could change for the population in public health. What do you think would be your primary objective?
It's a really good question. There's a lot of different answers to that and a lot of different ways to go. I think probably the most applicable and one that I like to talk about a lot right now is, and I think is a good thing for eye care in general, is, really getting out there and making sure our patients, and not even our patients, everyone, right, knows that we need to have an eye exam every year. Some people might say every other year, but I'd say at least once a year with dilation. And we all need to be brushing our teeth for the eyes, lid hygiene. Please do your warm compresses, your lid scrubs, and your nutraceuticals just as a good baseline.
Right.
I mean, so many other professions within healthcare already have laid this groundwork, and we've been around for, over 100 years as a profession. My great-grandfather graduated in 1890. So we need to, and we know these things. These are not new. And I really feel like, both ophthalmology and optometry really ought to be pushing that for all patients.
Right. Yeah. I agree. I think I always think from a nutritional standpoint, we ignore the eyes a bit. There's always like, do this, it'll help improve your skin, and all these different facets. And not just talking like nutraceuticals or vitamins and things like that for the eye, but just general nutrition. How the eyes are an extension of your brain. You need to eat well, otherwise things are going to fall apart.
Yeah, because why do we talk about making sure you get your calcium, your bones? Why do we talk about things for the teeth? It's we know all of this, but very rarely do you hear somebody other than saying I'm going to eat more carrots for my eyes, and then we go, not really. But it's I think
vitamin A deficiency is so rare. Unless somebody's just deficient in calories to begin with.
Right, exactly. So I think the conversation and really getting the public more aware about what is needed for care for their eyes, I think is important.
Well, Cecelia, thank you so much for being a guest on the show. I really appreciate it. Perhaps we'll have you back again to talk more about whatever next projects you're working on.
Absolutely. Thank you for having me.
So that was our episode for today. Thank you so much for tuning in. If you did find value in this episode and like to hear more, make sure to subscribe to us either on YouTube or follow us on wherever you get your podcasts from. Otherwise, I appreciate you guys listening in and hope you have a fantastic